Okay. This
I've got
works.
45, whatever, but we've got to give you 5 minutes. But maybe because obviously this students that kind of know. Yeah, we're not like too strict on. No, I mean,
And there's this buffer of 5 minutes between speakers. I've never seen that before.
yeah.
That's not a buffer. That's for all the questions you're going to be received.
But isn't it? There's 10 minutes for the
Yeah,
speaker, which is
five
5
minutes of report and 5 minutes of question.
It's 5-minute Q&A.
minutes to 5 minutes Q&A, the 10 minutes allocated against speaks time, and then there's 5 minutes buffer
Could be
between.
only two, but
No, 5 minutes for report.
you,
Yesterday, there
Give
was
me
a session that had
10
5 minutes in between, but
Ah.
today there are only 2 minutes. It was just depending on,
Ah, I see.
it's not the same.
That 5 minutes is good, so don't feel like we have to stop. We've had people.
Yeah, I won't be like pulling
No,
you
it's-
off.
I read it yesterday.
were you?
I know, I didn't read the.
You look like you survived okay. Look, Tim really wanted lots of questions.
Hard to do that.
So you wanted controversy, did you? Oh,
I don't mind.
okay, I'll throw in one.
Good. Okay, so I think that's up. It's recording. It's unmuted and it's sharing the screen. And we're the only people. So far. You're up in 4 minutes. Shall I
Yeah.
let people know?
Yeah, maybe you let Betty know.
Because she's the other two.
Did you want another coach here?
No, not really, but
Okay.
How long is our reports?
so we might have a 4th person who I obviously didn't have their bio yesterday because Irene only just told me a minute ago.
A 4th person in the session.
Perhaps a student who didn't get a visa and might be coming.
What, how would you
Very
like
fast.
to distribute the work, or do you want to do intro? And have
Oh,
the
do you
bio?
wanna, sure, intro meaning the,
Intros meaning. No, intros are short.
how about you just do the
Legal
first
bio.
two, and I'll
Okay.
use, if that
So-
student comes. You like?
Yeah.
So we have John first.
Yeah, John's first.
Happy
and
to
then
introduce
Spencer.
John.
Yeah.
Yes, John, so this is, you know how to respond, Dr. Rani.
Shab- I don't know, I assume. Dr. Ran,
Dr. Rani is okay.
yeah,
You can tell us, and then you do, Cherie and, is it
Yeah.
Asrina?
it is, so I put her bio on my phone because I found it online, but just now. So if she does come, I'm happy to do that one, and then maybe you do the questions. if you want to know the questions you want.
And what would you,
Yeah.
are they loaded?
They are, 2 are loaded, I haven't met.
I saw
Dr.
Cherie, there's Cherie.
Yeah, and John's put his, but I don't know where he comes from. Yeah, I think. Is anyone a speaker in this?
Yeah,
Oh, yeah, perfect. Are you Dr. Yeah, Shilvarani, yeah. If you're happy to,
Yeah.
just put your slide.
Is it pronounced Shoba?
Gone for
Or
that.
is it
Yeah,
Shobha?
Shobha. It's a
Shobha.
H.
Oh, I choose.
Yes.
Okay,
I
perfect.
think it's still there. Did
Yeah,
you- John, I don't know you. How am
no,
I
no,
supposed to
that's not there.
introduce you?
It's just, that's okay. Just
Uh,
there.
Very shortly, very briefly, and
You know, you got a big bio, you don't want to read it.
it says on it, it lists my BARPA association. I asked them to change that, so I don't know.
Why is this now blurry?
It's more about domestic.
It is, right?
Yeah.
I'm not quite sure.
I think.
Oh, that's better.
We have some 5 minutes on
I don't think I can.
Yeah, but if it's a little bit more, it's not a problem. So, USB, there you go, I'll let you find it.
Find them short paper.
Perfect, so just keep that open,
Yeah.
yes, not yet, because you're second. So,
Okay, okay.
yeah, so we can just do that.
Yeah.
and
Have
then-
you shared already?
Yeah, no, it's, yeah, it is sharing, and it is recording, Carl said, and it is.
So we need to stop sharing that one.
Yeah, I know, I'm just trying to get out of it though.
Stop sharing on the dot, on the red dot, yeah.
Oh, no, I just want to open John's one. There we go.
Can you do it at the same time? Yeah,
Yeah.
good. Beautiful. All right, shall we start?
I think so.
Do we time for each other? You time for? this one? I'm happy to do it. I'm happy to. I'm happy to have it going, just in case, but. Do we have anyone in the Chicago hub? No, is it, which hub is it? Yeah, they might just watch these online, I guess.
Okay, so welcome everybody. This is short oral presentation session number 5, and our first speaker is Mr. John Jackson, Federation of Asian Pharmaceutical Associations, Australia. Now, his talk is called Identification of Key Medicine Safety Interventions for Australian Pharmacists. As you all know, we have 5 minutes to deliver the talk, and we open for questions after. But I'm going to read a short bio of my dear friend John. John Jackson is a pharmacist with broad professional experience and expertise in pharmacy policy and governance. He's currently president of Western Pacific Pharmaceutical Forum, chair of Social and Administrative Pharmacy section of the Federation of Asian Pharmaceutical Associations, and president of the Victorian branch of the Pharmaceutical Society of Australia. John is engaged in practice-based research at the Monash University Faculty of Pharmacy and Pharmaceutical Sciences, and is proprietor of a not-for-profit community pharmacy in Collingwood, Victoria. I'd love to know more about that. He has previously operated hospital pharmacy services in both the public and private sectors, and undertaken consultancies to review and enhance pharmacy services in hospital, community, and residential aged care. John has had a long-standing involvement with advocacy and education, with a focus on social and administrative aspects of pharmacist practice. John, would you like to take the stage?
Thank you for that. Should never write those things. People are going to read them in front of you. Look, thank you again for the opportunity to speak in this conference. And again, congratulations to the organisers. This presentation is about, as you see, medicine safety. And look, we would all agree that the role of the pharmacist extends well beyond the supply of medicine. We have a significant responsibility for the safe and appropriate use of medicines. And it was suggested that we need lots of questions, and to do that, you have to be controversial. So I will start with the statement, what have pharmacists been doing in relation to medicine safety today? Because, as most of you would know, a couple of years ago, the federal government declared medicine safety and the quality use of medicines a national health priority. It was, of course, stimulated in part by a publication you see here, Medicine Safety Take Care, by one of the professional organisations. The objective of the work that led to this presentation was to try to identify and prioritise some of the areas in which pharmacists could intervene to reduce the harm associated with the use of medicines. So if we've got this role, how do we use our time and effort best to address this national health priority? We established, Amy Page, my co-researcher, and I established an expert advisory committee to try to identify potential areas that pharmacists could be involved with. That expert advisory committee helped develop some tools that would be used in a workshop that was conducted at the APSA. It was APSA conference a couple of years ago. We used a nominal group technique during that workshop to assess and prioritise the areas that were identified by the expert advisory group, and then the workshop split into subgroups, and they worked on the allocated priority interventions to try to work out what pharmacists could do. And you can see on the slide the criteria that we used to assess the potential interventions. They had to be things that had high level of engagement for pharmacists and that were very significant to medication safety issues, and also the list of things that we asked the subgroups in the workshop to use to try to identify the intervention that they thought pharmacists should do in that particular area. So this is a table of the potential areas of engagement that the expert advisory group established, and we did not set out to do this, but you can see that they actually fell down into 5 things: professional functions of pharmacists, factors relating to consumers, the life stages of patients, obviously some aspects of medicines, and then the resources. And of course, through the workshop, and I don't have got time to go through all of these, but these were the 5 priority areas that the workshop identified. Not surprisingly, number 1 is polypharmacy, health literacy was second, etc. Geriatrics, high-risk medicines, and potentially inappropriate medicine use. Now, what I can do in the time available is just look at what the subgroups identified as the possible intervention. And the first one on polypharmacy was to embed pharmacists in primary care, such as general medical practices. And of course, we are aware that this is an evolving area of practice, but it was something that that particular subgroup thought really should be a focus, and they put it as the highest priority. In terms of health literacy, it was for pharmacists to actually do something that they normally do, counsel, but obviously a more comprehensive engagement with the patient's electronic record, a more informed counselling process, and of course they identified that this should be remunerated in some way. In terms of geriatrics, we recognise this is the group that obviously are heavy users of medicines and obviously with multi-morbidities. And so the need for pharmacists to not just do medication use reviews, but to follow up, and for pharmacists to initiate these reviews were part of the process. In terms of high-risk medicines, to monitor using therapeutic drug monitoring, and in terms of potentially inappropriate medicines, to get engaged through some form of remunerated protocol-based process to address those. There's the group there. What I'd like to finish with is some observations about this, and it's in a way disappointing. They are all things that we already do. Where was the novel interventions that we could engage with as pharmacists? The other factors that were notable is the need for remuneration, the fact that a lot of these should be pharmacist initiated, and they should not be site specific. So there were some criteria that were common to those. In conclusion, I'd like to actually thank the workshop participants and also obviously the expert advisory group members. Thank you very much.
Thank you. Bravo, just under 5 minutes, John. Any questions? Did he go too fast?
I was under 3.
Should I come up?
I can repeat the question.
But because it's, yes. Sorry about that. I should have. realized.
Okay, thank you very much. Thank you, John. That was a very interesting presentation, and I agree with you that pharmacists have such an important role with this. And I think remuneration is a big issue because, you know, pharmacist wages are not where they should be, I feel. So where do you think the remuneration should be? Directly to the pharmacist engaged with this activity, or to the pharmacy owner? Because the pharmacy owner often doesn't pass on the benefits of all the hard work of the community pharmacists.
We know that the majority of pharmacists who are now engaged in enhanced professional activities, whether that be medication use reviews in pharmacies or even administration of vaccination, do not get increased remuneration. So you're correct that any increased revenue stream stops at the pharmacy. I'd refer you back to the presentation I gave yesterday where I put forward a framework for pharmacist remuneration, which would split the funding flowing to a pharmacy into that part that's for the technical and commercial aspects, which would go to the proprietor, and split it into another part with the professional service, some of which would still flow to the proprietor, but a significant part should flow to the pharmacist doing the service.
Any further questions? John, you said like you were disappointed with what they came back with and that the results were just what we do anyway, just a bit of an extension. What would have made you a bit more excited? Not the wrong way to answer.
No, it's a good one. It's a good one. And I have thought about this. What is it that pharmacists could and
What
should
do
be
you want?
doing?
What do you want? Yes.
Betty, I'd put it to you this way. At the moment, the greatest opportunity for pharmacists to be engaged with patients is at the time of supply and dispensing. And we know from experience overseas that a lot of that dispensing process will become centralised and distant supply, and it won't go through community pharmacies. So we have to find a new way for pharmacists to engage. Now, a lot of people talk about pharmacists prescribing, but prescribing is the beginning of a process, and often the issues arise later in the process. So we've got to get the pharmacists engaged at a point when the issues arise. So that might be by having consultant pharmacists within pharmacies or premises that people could come to, pharmacists who are referred to by GPs, not just to do a medication review, but to address the issues of the patient more broadly. So it's actually distributing pharmacists into more points in the patient care pathway.
Right. Are we losing opportunities perhaps? Tim has a question for you, then it's a lot.
Thanks very much, John. Do you see a distinction between technical services such as vaccination and cognitive pharmaceutical services such as, for example, medication management review?
We are being recorded, so I suppose I should be careful what I say, but to be perfectly honest, personal opinion, globally, no, it's fine. I've said this to FIP. Globally, there's been a great push by FIP to expand pharmacists' role in vaccination, and during the pandemic, it's been appropriate. And of course, Australia has been very engaged in that well prior to the pandemic, and places like America were light years ahead of us. It's a technical process, Tim. It is purely a technical process that does not utilise the key expertise of pharmacists. And so for me, the only role of vaccination in pharmacy is to change the relationship between other parts of the health system, the patients and pharmacists, to have pharmacists being engaged in hands-on engagement, to put in consulting rooms, to get the pharmacist seen as a carer. But I hope it does not stop as just a technician administering vaccines, because if that's all it is, it will be running pharmacy up a dead end.
Here's another sane colleague of the house.
Thank you. I think it's really interesting that sometimes the technical processes give us an opportunity, an incidental opportunity for literacy improvement. So how else can we leverage some of the current processes for that literacy?
How else can we? Yeah, it's interesting. You are correct, the technical process. Lloyd Sansom also always said that the dispensing episode is the best opportunity for pharmacists to intervene. And the majority of pharmacists do treat, unfortunately, dispensing as a technical process. If they then add in the professional, that's fantastic. And the same thing could apply with vaccination. How else do we get pharmacists engaged? Is that the crux of the question? Monitoring. There has to be, for a small group of patients, those who are at high risk because of age, comorbidities, multiple drugs, some program monitoring that triggers a need for pharmacist review. Obamacare, that legislation in America, legislated insurers to fund medication therapy management. Now, I do have dispute with what the American Pharmacists Association have ended up defining as medication therapy management. It's a very broad definition. But we should have the capacity, we should have triggers in the system through monitoring that lead to pharmacists, patients being referred to pharmacists to undertake some form of medication therapy review. Not a specific review as currently occurs, because that's other parts of the health system telling us what to do. We should apply our own expertise based upon our judgment.
Shall we let John? Oh, no.
Sorry.
Let's let him off the hook.
A lot of controversy.
In UK, where we are moving to hub and spoke dispensing, that's probably what we're referring to. The actual medicines will still be given out in the pharmacy and they'll be tagged if the patient needs counselling. And we have what's called the new medicine service, the variety of medicines where when you get it for the first time, you get extra counselling, you get follow-up. We also have pharmacists embedded now in general practice. And they are doing really big structured medication reviews as independent practitioners. And so that's going on as well. So people are getting reviews within the system, but dispensing is becoming very technical and moving away from pharmacy. And I think that is the way to go.
Thanks, Claire. Look, I totally agree with you, and thanks for bringing those insights. And if I can, 1 second. Both what the UK have in the new medicine service and what New Zealand have in their long-term care service
Yeah,
are service provision models that use a trigger. In New Zealand, it's multiple dispensing episodes. In the UK, it's particular medicines that patients been prescribed that then lead for continuous and repetitive engagement. And we cannot achieve change with one-off interventions. It's
No,
got to be repeated.
exactly. Yeah.
And so that's an important part of it. Your point about the hub and spoke, and I've been watching the legislative
It's
change.
interesting,
You know, the Netherlands have had a process for many years where you would dispense the prescription in the pharmacy first up, and then often your wholesaler would dispense subsequent supplies, which might come back to you to supply the patient or might go directly to the patient's home. And the Americans have already shown that that's a very popular process. How do
But
we
we order
engage?
everything else online, don't we? And if you've
You
got,
do.
if you've got a repeat, like I have thyroxine, I don't want people to go to my pharmacy to get it. I want it to come through my door, and I don't have myself. So it's an interesting one.
Get out of business.
You're not done yet.
So,
You want a conference?
It's my call.
so, we in Australia, do something similar what the UK does. How can we try to avoid missing, communication between the actual pharmacist and the actual patient?
So the question's about the communication between the pharmacist.
Getting
Do you mean online?
pharmacist, care or the service or the counseling to the patient?
Workshop this morning was discussing how pharmacists need to be educated to act, not just in therapeutics, but in this aspect of communication and human behavior. We've talked about it for many years. I still don't think we're getting it quite right. I think the circumstance of that communication has changed. The digital world means a lot of it is typed through to Google and other sources. So this is what I think we need to actually understand in institutions like this, so that when our graduates go out, they are actually versed in that. So I totally agree with you. It does come down to communication. I think that's a key element of this particular interest group.
Anyone else like to ask John? Please keep his brain, no? Okay. Thank you, John. Can we all? Okay. It's now my great pleasure to introduce to you Dr. Shobha Rani.
Kill that slide.
Can you?
Yeah, I'll just.
Yes. Okay. So a short introduction to Dr. Rani. Dr. Rani is the director of the PharmD program at Al Amin College of Pharmacy, Bangalore. She is a professor and head of the Department of Pharmacy Practice. She has 36 years of teaching and research experience. Dr. Shobha was the past dean in pharmacy faculty at Rajiv Gandhi University of Health Sciences, Karnataka. She was also chairperson of the Board of Studies of Postgraduate Program in Pharmacy at Rajiv Gandhi University.
Dr. Shobha has also been the academic council member of the university. She has more than 100 research publications and more than 150 presentations at national and international journals, as well as national international conferences. Dr. Shobha has authored, edited 5 books in pharmacy. Dr. Shobha has widely traveled and visited about 15 countries to attend WHO workshops and conferences, to give talks and present her research work. She is the advisor for the Indian Journal of Pharmacy Practice. Her areas of interest are pharmacokinetics, pharmacoeconomics, and pharmacovigilance. So I invite Dr. Rani to the podium to speak to us about the evaluation of impact of educational intervention on knowledge, attitude, and practices of ambulatory patients regarding antibiotic use. Thank you very much.
Good morning, everybody. Thank you for the introduction.
Thank you.
So now, I'll be presenting a short paper on evaluation of impact of educational intervention on the knowledge, attitude, and practice of ambulatory patients regarding the antibiotic use. So as all of us know, antibiotic use is a main concern, not only in India, but across the world. So I think I can skip this because all of us know that what are antibiotics. And according to WHO, more than half of all drugs are prescribed, delivered, or marketed incorrectly, and half of all the patients take them, do not take them correctly. And irrational antibiotic use is a worldwide issue. There is increased resistance, a greater treatment cost, then increased hospitalization, and unpleasant drug responses. The major causes, as all of us know, are not completing the course, skipping the doses, reusing the leftover and expired medication, obtaining and use of antimicrobials without prescription, and self-medication. WHO considers antibiotic resistance as one of the main issues that threatens the public health. Antimicrobial resistance correlates with increased number of illnesses, mortality, and healthcare costs. And irrational use leads to AMR. And patient education is a proven method to influence patients' attitude and improve their knowledge and behavior. And we Pharmacy College, we have a department of pharmacy practice at St. Philomena's Hospital, which is a tertiary care hospital. So there we are a part of the antibiotic stewardship program. And we try by using projects and by various means to educate both the prescribers as well as the patients, the nursing faculty, the pharmacists, everyone, all the healthcare workers, as well as the patients. We try to educate them regarding the appropriate use of antibiotics. And then we try to see that, there is a rational use of antibiotics in our hospital. So now KAP, that is Knowledge Attitude Practice Survey, it's a representative study of specific population to collect information on what is known, believed, and done in relation to a particular topic. And knowledge, attitude, and practice could be evaluated using a standard questionnaire. So in view of the above, the present work was carried out to assess the knowledge, attitude, and practice relating to the antibiotic use among the patients at baseline. And then we provided the educational intervention and then reassessed the KAP to see if it has made any impact. So the objectives of this study were to assess the KAP regarding antibiotic use at baseline using a standard questionnaire, then to provide patient education through information leaflet, as well as one-to-one communication regarding the rational use of antibiotics, and to reassess the KAP regarding antibiotic use using the same standard questionnaire after 1 month of follow-up, and to compare the results before and after the intervention to see if it has had any impact. So the study site was St. Philomena's Hospital, Bangalore, which is a 300-bedded tertiary care hospital. And the study period was for 9 months. It's a prospective interventional study. Patients above 18 years of age of either gender who are prescribed with antibiotics and who were willing to participate in the study were included. Pediatrics were excluded in the study. And I had a research student, like we were a team, me, the medical director, Dr. Shankar Prasad, and a student. So the student, research student, she went around collecting the information. So she enrolled the patients who were prescribed with antibiotics and who were willing to take part in the study. And after referring to the previous similar studies regarding the KAP, we designed a questionnaire and then we adapted that questionnaire in our study. The prepared questionnaire was reviewed and assessed by subject experts. We had a team, again, 3-4 doctors, as well as a pharmacologist and myself. We looked for its content, design, relevance, readability, appropriateness, and so on. It was pilot tested in about 15 patients before administering to the patients. The quantitative content validity of the questionnaire was ascertained using Lashy content validity. Then the content validity ratio was calculated for each item, that is each question, and items with CVR score of 0.7 or above were selected. And such a validated standard questionnaires were administered to the patients and their answers were noted. Education about the appropriate use was given to the patients with the help of patient education leaflet. The questionnaire was re-administered and the difference in the KAP was evaluated before and after using student parity test, using the statistical test. And quickly going through the results. So we, about 100 patients were enrolled.
5 minutes is up.
Okay, so I'll just, yeah.
Wrap it up, yeah.
I think I'll skip the demography. You can just see 51 female. And this was the distribution with respect to the age. With respect to, this is just the demography, we just, their educational qualification, occupation, economic status. And what was the infectious, the highest thing in our hospital was upper respiratory tract infection, 35%. Then the number of patients, 70% were with upper respiratory tract infection, followed with UTI and then lower respiratory. And the most commonly prescribed ones in these. About 37% were doing self-medication for cough with fever. And antibiotics used in self-medication, maximum were amoxicillin and clavulanic acid, 28%, followed with levofloxacin. And the possible reasons for inappropriate use, about 35% did not complete the course as they were feeling better. And 15% the forgetfulness, and then 15% because of they couldn't afford, low income, they couldn't afford the medication. And they were getting information from internet, family and friends, so they were doing self-medication, 25%. So this is regarding validation of the questionnaire. The knowledge of patients regarding the antibiotic use. About 89% responded that amoxicillin is an antibiotic. So, and antibiotics are effective. These were the questions. Antibiotics, should I just scroll through this because of lack of time? So these were the questions. Antibiotics are effective against bacteria. They help in treating cold. 84% of the patients responded yes to that. This has to be noted. Antibiotics help in treating cold. And paracetamol is an antibiotic. 45% of them believed so. And 89% said they do not know whether amoxicillin is an antibiotic or not. And 57% did not know. So these are the questions regarding the attitude. I can provide this presentation for anyone who is interested to go through. And these were some of the questions with regard to practice.
So what was it?
Yeah, I'll go off to the
Just- yeah.
conclusion. This I can provide the presentation for those who are interested. So we did the statistical test. And the hypothesis stating that there is a difference in before and after intervention was accepted. That means the key finding is they did not have sufficient knowledge regarding antibiotic use. They lacked understanding, particularly with regard to the role of antibiotics in viral illnesses. And then, and overall, it can be concluded that the education by a clinical pharmacy professional about the rational use of antibiotics helped in improving the knowledge, attitude, and practice of antibiotics.
Thank you so much,
This was
Doctor.
a patient information leaflet what we prepared in English as well as we prepared in the local languages to Kannada, Hindi, and all.
So any questions for Doctor?
Sorry, I had to rush through it because of the
Yeah,
time.
well, there was a lot to get through. Any questions?
I can ask.
Yeah.
I think it's, you know, obviously we didn't get to see all the results, but I think the key message was that this
Yeah.
intervention worked, and I'm just, I guess, interested, do you have plans to expand it to other
Yes.
hospitals or? Yeah?
Yes, definitely.
Okay, so you're implementing it in other hospitals or?
Yeah,
Yeah.
we do have contacts with certain hospitals.
Great.
So we will be definitely extending to the other hospitals as well. And we also did a similar study in the prescribers before this.
Oh, fantastic.
We also tried to find out about interns, medical interns, and then junior doctors who were just prescribing irrationally. So we thought we should educate them. So a similar thing was done with the nursing staff also.
Mhm.
So it's an ongoing study. This is a departmental work which we keep continuing with all the healthcare professionals and different hospitals as well.
Fantastic.
I wonder if I could ask about the general culture of self-medication.
Yeah,
What do you think is the way around it? It is very common, not just in
yeah, it is
India,
very,
but around the region. And what do you think is appropriate?
for to prevent self-medication.
Mm-hmm.
I think only the awareness only, according to me. You should make them aware that, for example, there was a patient who took ofloxacin irrationally, and then he ended up with Stevens-Johnson syndrome. Actually, we saw the patient. 1 week he was taking for fever ofloxacin, and then he came back with these symptoms, and then he passed away also. He was admitted, and after 2 weeks he expired. So we have to, wherever possible, whenever possible, we have to tell them that there are a lot of adverse effects. We have to emphasize on that.
And maybe the regulation?
Yeah,
Framework.
regulation. So what we are
Apply.
doing is we are trying to publish so that there is evidence. And then only then the regulators will take a note of it.
Yes.
So we are trying to make publications and then circulate it. We are in-house circulating, plus as the Indian Journal of Pharmacy Practice, there is a journal which we have brought out, and I'm the advisor for that. We are encouraging not only our students across the country, all the Indian colleges which are running the PharmD program, we are requesting them to publish our articles so that people get to know. So I feel the only answer is awareness, building awareness.
Thank you very much.
Thank you.
Thank you.
Okay, up next, we have Dr. Cherie Lucas from the University of Technology, Sydney. Cherie will be talking about the development of a reflective practice toolkit designed to support student learning and capacity to work respectfully with Aboriginal communities. A little bit about Cherie, who is a colleague and friend. She's a senior lecturer and clinical education manager for placements at UTS.
No longer a clinical education manager since
She has changed her roles recently, and is the recipient of the 2019 Australian Award for University Teaching Citation for the individual category Outstanding Contribution to Student Learning. She works collaboratively with Indigenous health and across disciplines, and this current research that she's presenting on today relates to the development of a toolkit to enhance student learning and cultural safety. Welcome, Cherie.
Thank you very much. Thanks for this opportunity. This is actually just a snapshot in 5 minutes, so I am going to do my very best to present this body of work. So why did we need a reflective practice toolkit? We called it the RAP toolkit, working respectively with Aboriginal people. And we thought we needed it for a number of reasons, and many universities are going down this track. We've introduced the graduate attribute, the Indigenous graduate attribute at UTS. And like I said, many of the universities are going down this track. But also we send our students out to both rural Indigenous sites and also more recently in one urban site as well. So we wanted to support our non-Indigenous students and prepare them to be working respectfully in these Indigenous communities, but also to ensure no harm. And this was all related to cultural safety preparation. Okay, so we wanted to design a toolkit, but it was really difficult. I mean, I led the design of this, but I'm not an Indigenous person. My area of expertise is reflective practice. I needed to engage with Indigenous academics and people that came from the Indigenous communities, that worked in the communities. And also I was at that time clinical placement manager, and I was really concerned about how the students were performing in these communities and what sort of preparation they had. So that was the premise of why we decided to work on this particular toolkit. So there were kind of three phases, two major phases. We wanted to gain the insights from both the students' perspective, but also the clinical supervisor's perspective. And so we did two separate studies. Now, the students that were engaged in study number one had already been immersed in a rural community for 4 weeks prior. So within that last 6-month period, they had at least 4 weeks immersion in a rural community. And there was an aspect there that they had to engage in Indigenous health in some capacity. And so we then, they were the students that were derived from that study. And we gave them the opportunity to be immersed in the urban Redfern community for some modules, for a historical walk, for meeting some of the elders and the community members as well. And so we wanted to gain their insights into what was different between the rural and the urban communities, whether they struggled in certain areas, whether they felt they needed some extra support. And so we did a pre and post test with the immersion with the urban community, and then we did a follow-up focus group with those sorts of questions. The clinical supervisors had focus groups, and I made sure there was an even range from the rural and urban areas. So we got both perspectives, and the clinical supervisors weren't not necessarily from pharmacy. So we had it as a allied health as well discipline included. So physiotherapy, genetic counselling, orthoptics, obviously nursing, pharmacy, and speech pathology. So we did have some clinical supervisors in that area. And then once we had some elements of the toolkit and gained some insights from these two studies, we took it to just a stakeholder group. And it was an informal stakeholder group. We invited community members, Indigenous community members from the Redfern Community Centre, some Indigenous academics, Indigenous elders in the area, and a student representative, plus a couple of pharmacists that were in both areas. So these are two of the studies that came out of this, and the elements of the toolkit are discussed in both of those studies. So you're welcome to have a look at that. But I'm sure you want to know what the inclusions of the toolkit entail. So we had developed a couple of counselling videos. We used Indigenous academics to be the patients for these. That obviously saved quite a lot of costs involved. And we had a pharmacist, a practicing pharmacist that was counselling these two particular patients. And the counselling were exemplar in terms of how they counselled in terms of the medications. They were perfectly counselled on those medications. The elements in the counselling that we wanted to workshop were some of the other elements, some of the services that we didn't know, the closing the gap service. They weren't listening to the patient. The patient was thinking, you know, oh, I've got high blood pressure, or if this is a good medication, I'm going to give it to my mom. Or do you think that, you know, like there was a few things that the counselling had some flaws in there. The medication counselling was exemplar, but the other parts of the counselling had some flaws, and we workshopped that. The other part of the toolkit was a research component. Initially, this toolkit was rolled out just before COVID shut down, and our students who went to rural areas and so forth. We asked them to research those areas. So in terms of the COVID situation, we asked them to research Redfern, and they did research on the services involved and historical walks and Aboriginal slang and so forth. And there's a reflective practice component as well. They have to look at some reflective practice models and work through those. And we had some really good feedback from the students, having this bit of understanding about, cultural safety and what that involves. And just wanted to acknowledge some of the facilitators of the groups. Focus groups were Indigenous facilitators, Indigenous academics. And obviously understanding our own sort of identity was a big thing that came out of this. I'm just running through this, I know I'm over time. So just acknowledgements. I got a $20,000 sphere grant to do this study, and I obviously had a lot of help with some wonderful people along the way at different stages. So I just wanted to, and also the toolkit itself has got some beautiful artwork from an Indigenous person as well. We wanted to make it as authentic as possible, and we engaged everything. And it actually is a kind of a toolkit where you can actually take to your workshop, as well as the videos, as well as a map of Australia with all the countries and getting to know people. And yeah, that's it. Thank you.
Fantastic. Thank you, Cherie. Any questions for Cherie? Right.
Just a second. You mentioned some of the students went to rural areas. Was it just a certain, specific rural areas, or did the UTS students go to a broad range? Because I guess the challenge is for the different.
Yeah, so they're all offered the rural areas. So I was involved in all the coordination of that. And we had those particular ones that came from there, went to Geraldton and Port Hedland, very highly Indigenous populated areas. There was 8 on the list. Yes. So
okay. Yeah, and I was just wondering as far as the challenge of, I guess, different, as you mentioned, there are different groups of people throughout Australia and different customs, and how did you manage that? Or was it sort of a broad taster?
Yes, it is a broad taster. Each one of those groups had their own sort of cultural safety modules that the student had to undertake depending on the area as well. So they did have some preparation before going to those areas. But it is a taster. They are most there for 4 weeks, and the community, they're involved with the community as well. Whatever the community activities are, even outside of pharmacies, some of them were sent to like drug rehab centres and so forth. So completely different, very broad.
Sounds great.
Thank you. What a great initiative. How do you see that being motivated?
Yeah, so we embedded it into the first year's pharmacy, Master of Pharmacy course in the 2nd semester, just prior to them going out to the possibility of rural placements. And those who didn't choose rural, they had the opportunity to research Redfern, for example. I mean, we gave it across the board. It has been flagged for the nursing discipline as well, because it's a very broad modules in here, not tailored specifically for pharmacy. Cultural safety is obviously a broad area, and both nursing and pharmacy are involved in that preparation.
Any other questions for Cherie? I'll ask one. Do you have kind of like a vision of how something like this could be applied for already practicing pharmacists to make use of this kind of model?
Yeah, I think the students, because this is the first time they
early stages.
And the first time they were familiar with this, or was allowed to have the time in the curriculum. And then once, I mean, obviously there were students that went through, didn't have this. I really do think there should be perhaps maybe some CPD associated with this, or allocated CPD, because it will align to some scopes of practice. So if you are immersed in those areas, perhaps that CPD, 2 or 3 of the group 2s can be related to some of the research aspects of that. John, do you want to say something?
Yes.
I love the fact that we're just seeing this emergence of attention to the requirements of the Indigenous communities. Congratulations on that. But I was just wondering when you thought about how this type of process could also be developed for awareness, cultural sensitivity to the LGBTQI.
Yes, so this is obviously a start. Part of the IGA, obviously, we've got to focus on, and part of our requirements focus on Indigenous, but there are other areas. And like we said, with cultural safety, it starts with cultural awareness. That's the first step, understanding that differences exist. That next step is cultural sensitivity. So where you're, what you identify with, you're reflecting on your experiences, your upbringing. It's a very self-exploring sort of side of things. Then the next step is cultural safety. That's the outcome of the education by the healthcare professionals to deem a service that's safe. And that is actually defined by the person receiving the service.
Yeah.
So it is very broad, but of course our requirements and being culturally capable, having the skills, knowledge, behaviours to have a developed service like this is very broad. It's not necessarily related to an Indigenous, but this is only one part of a bigger, probably a very big project.
Of course.
Another PhD somewhere.
Thank you, Cherie, and we do have one other delegate that may be joining the session, so I'll just double check that there isn't a Dr. Azrina Azhari here.
Azrina went to Basel in the end.
Okay, so we weren't sure which hub Azrina went to. Okay, good to know, and she's not online or anything like that?
I doubt it.
Yeah, okay,
She was changed to present in Basel.
okay, fantastic,
But,
that's good.
She couldn't get a visa from Malaysia to Australia.
Okay, good to know that she did make it to one of our hubs. Yes. All right, well then I guess that kind of concludes our session. We've got a few minutes before we change over to the next session. Please join me in once again congratulating Cherie, John, and Dr. Rani on their work. I'm sure they'll be around if you'd like to pick their brains a little bit more over the course of the day. Thank you. Can I just end the session?
Yeah, once you finish.
Taste Cafe, you have to find Carl and walk down with him because he has to literally carry from Taste.
CPC.
You might need more than one.